looking at the,
Camera two.
okay.
Hello again. My name is Reverend Gregory Holston, and this is Just Nation, a show dedicated to racial justice, faith, and issues in the city of Philadelphia and beyond. And again, well, I'm so glad to be here with you on this exciting and very special show today, as we have our guests here today, and of course our co-host, my co-host, Nia Holston. Glad that she is again with me on this program as we are starting our fourth season of all of these kinds of programs across these channels. And we're always excited, but even more excited for what's in store this year of all the issues of justice that we have to talk about and put a strong racial lens on. We have a lot to say this year in so many different ways.
Absolutely, absolutely. Thank you for that, Reverend Holston. And welcome everyone to the show. I'm Nia Holston. I'm so glad to join you all. And Reverend Holston alluded to it. The show is special. Every show is personal to us. Every show, touches some aspect of our lives. But this show in particular is going to be about the Black maternal health crisis and what's important to know about Black maternal health as it relates to people in Philadelphia. And it is especially personal, and I especially wanted to do it because I am myself pregnant. And I am really excited to be giving birth this fall. And so there are a lot of questions I've had, a lot of concerns that I've had, a lot of the statistics that I've heard. But I also feel very empowered by the experience and empowered by the birth workers, and particularly Black birth workers that I've been able to encounter during my pregnancy. And so I am really, really excited to share this personal journey and to talk about the impact and importance of it for all of us, because it really touches every single one of us, right? So I'm really excited to share that today. So I know Reverend Holston is excited about this show.
I'm trying to contain myself.
Yes.
And just excited over of another grandchild coming on the way. Excited for all the questions you have and all the things you've been going through, and our whole family. It's a very special time for all of us, and to be able to share this with all of you on this program is special to us too. And I hope that these issues that we raise can be talked about in your families as well, as we look to deal with Black maternal health in a real way, and that we value the lives of our children and as they're being brought into the world.
Absolutely, absolutely. So we're going to start to turn it over to our guests for today,
And
who
we
are.
have some very interesting guests.
We do have some very interesting guests. So I'm going to start. I'm going to introduce this side, and then I would like you to introduce that side. Okay.
Okay.
So I'm going to introduce someone who is very special to me. My own mother, Deborah Holston. Ms. Holston, can you tell us a little bit about yourself and how you come to this work?
Absolutely. I am new to the doula work, the birth worker work, but not new to mothering nor to the healthcare system. I'm formerly a retired Philadelphia School District teacher or educator. I have educated students at every grade level, every ability level, and my most recent has been with Central High School, retiring from there. It was indeed a pleasure, and it's also a pleasure to be here as part of your birth team and as an expectant grandmother.
Thank you. And so next I would like to introduce Titi Lolo Ogbagde.
Can I say that that woman on the end there is very attractive?
Flirting?
I believe he's flirting for the audience with Ms. Holston, who is his wife. But TT, would you introduce yourself, please?
So, my name is TT Lola Ogbaide, and I am a home birth midwife here in Philadelphia. I've been running my practice for the past 6 years now, servicing the Philadelphia area and a 45-minute radius of it. So I'm in Chester County, Montgomery County, a little bit in Jersey. And I'm also a lactation consultant as well too. I recently just got my IBCLC certificate, yes. I'm also excited for this episode. And I'm very grateful and thankful that I was able to make it to this panel.
Thank you for joining us.
And you'll give us a kind of more detail about what all that is.
I'll try, yeah.
Absolutely.
And also, we have two other guests on this side as well. And Jasmine, why don't you tell us a little bit about yourself?
Sure thing. I'm Jasmine Boyd. I consider myself to be a full spectrum doula, birth worker in the city of Philadelphia. I've been doing it for about 8.5 years. Originally started out to be supportive of my sister who was kind of contemplating her pregnancy and what she wanted to do. And from, just searching on Google, I found out about doula support in the city, found a doula training, trained, and then by the time I graduated, my sister was due to give birth to my niece. And 8 years later, she's here and she's doing well. And I've been just supporting people in the city since then, so I really enjoy it. I also recently just got a certified lactation counselor certificate, so I've been doing a lot more lactation support for families. Full spectrum in the sense that I just kind of support people along their reproductive care continuum and just providing that information and access to them. So,
thank you so much for being here.
Yeah, thank you.
And we want to hear a lot more about all of what you do.
Absolutely.
And Angelica, would you like to share?
Sure. Angelica Sanders. I am Chief of Staff for State Representative Morgan Cephas, who is co-chair of the Pennsylvania Black Maternal Health Caucus, who has been working in the maternal health space when it comes to policy, legislation, state investments, and for 7 years now. And in 2023, alongside Representative Gina Curry from Delaware County and Representative Latasha Mays from out in Pittsburgh, together they founded the Pennsylvania Black Maternal Health Caucus in the Pennsylvania General Assembly, October of 2023. So we're coming up on 2 years of really honing in on trying to address the issue of Black maternal health at the state level when it comes to policy and legislation. And we love working alongside our stakeholders who are doing the work on the ground and really couldn't do the work without them, but want to make sure that the policies and investments that are taking place at the state level are doing what they need to do to support our mothers and families.
So glad to have you here.
Yes.
And we want to, again, get into all the detail around those pieces of legislation. It's pretty unique, isn't it, to have this kind of caucus compared to other states and other areas. So we want to hear about that.
Yes. So thank you all for introducing yourself. So TT, I'm actually going to start with you.
Yeah.
So we've heard a few terms today. We've heard doula, we've heard midwife. We also know there's the traditional obstetrician gynecologist. We've heard full spectrum doula. We've heard lactation consultant. So can you tell us what these terms mean and what's the importance of each? And anyone, if anyone has anything to share, please feel free to dive in as well.
We could start off with what a midwife is. Midwives are pretty much when there were babies being born in this country, it was midwives that were helping families, helping to deliver these babies in their homes. So that's something that's not new to this country, new to our history of being in this country. And then a little bit after that, we had the introduction of OBs, which are more of the traditional hospital route. There are some OBs that are giving birth at home. It's a little bit hard for them to do that, so you tend to see an OB in the hospital, whereas a midwife is more so can be found in the hospital, in birth centers, and at home practices, and they're more of the traditional provider, the traditional obstetric provider, where I can speak for myself specifically. I'm a CPM, so I'm a certified professional midwife. So I'm a direct entry midwife, and I surpassed the nursing route of becoming a midwife. So the things that are entailed in my scope of practice are a little bit low intervention, more so using the elements of what we can control, body mechanics, emotional, physical, and mental, all of the things encompassing to help give birth to babies. Versus in the hospital, they're more, they have access to medication, procedures, surgery rooms and things like that. It is not uncommon for an obstetric person in this country to be really well versed in surgeries, whereas a midwife is more so low intervention, natural birth, or whatever that means. And then you have doulas who can work side of an OB and a midwife. And they are, I like to think of them like a human epidural. This is the person that makes you feel comfortable at home. This is the person that makes you comfortable in any setting that you're in. Makes sure that you're well educated, you're making these decisions with a clear mind, and really just always refocusing the energy back into the birthing person, which is really nice. Then you have lactation consultants where they specifically talk about breastfeeding and how to feed your baby and all that good stuff.
Yeah. Does anyone want to add anything to anything that TT said?
Yeah, TT, did a great job in kind of spilling everything over. I feel like with doula support, there are different types of doulas that come into it. So I talked about being a full spectrum doula, supporting people along the reproductive care continuum, but there are different doulas for things. So there are some fertility doulas who are helping people trying to get pregnant or interested in conceiving, so kind of supporting them along that journey. Prenatal doulas who help, they might do some things like childbirth education, getting clients ready for their birth by giving them access to information, knowing their birthing rights, and even helping them kind of create a birth plan for when they do go into labor and want to deliver, to kind of get a clear, concise plan set. And then there's postpartum doulas as well who support folks after the birth, and they can do a lot of range of care, like supporting infants, helping the parents with the child, as well as lactation support as well.
Yeah.
So you can run the gambit with doula support for
Yeah,
sure.
that's great. That's great. And I recently learned that there are also abortion doulas and death doulas as well to help people along these processes. Now, Ms. Holston, do doulas, are they involved in making medical decisions for their clients, or are they, how are they involved in that at all?
Not at all. Not at all. We leave that to the trained professionals. We, however, provide comfort, support, advocacy, education. We help our clients, whether they are the parents, male or female, or any client. We help them. We come alongside of them. We are there to help them understand the process and to feel comfortable in spaces where they are not always in. It sometimes can be intimidating to be in those spaces in the hospital, or even talking with your provider. So we may go to an appointment with the mother, the expectant mother, or the expectant parent, should I say. And we definitely are there to visit and to train and educate. We teach them how to make decisions with information, informed decisions. We teach them things like getting informed consent, because your body is your body. And so people just don't have the right to just go in and touch your body. You know, we teach them the kind of phrases, like if someone starts out by saying, "I'm just gonna do this," that's not getting permission. But if they start out with, "Do you mind?" or "May I touch you here?" That's respecting your personhood, respecting your body. And so we want to teach them to start cueing into hearing things like that. And then we're also involved in the actual birth process. We are trained to be constantly there throughout the whole birth process, because it's one thing for parents to be in a situation where the mother may be going through labor and she's concentrating on labor. and the support person is trying to comfort them. But the doula is there to watch the whole picture, to provide that warmth, to have them also feel secure, and to have someone there to trust, and also someone there to kind of watch over how things are going. And if there are questions, we kind of ask or answer what we are able to answer, and then we also would refer back to that person who is doing the medical procedure to make that a little clearer for our client. So, so in my role, I would be there on behalf of the parent solely, and they know that, and I make that very, very clear in what I do, that I am there for them. And so that's how it is. And then people tend to feel, I think, a little more comfortable to know that somebody's watching. And also, when you're in those spaces, when people know that they're being watched, and I'm not spying, I'm just there as a presence. And being there as a presence, it counts for a whole lot in what is happening in and with parenting and giving birth. So yeah, it's really a sacred work, but it's a work of love. It's a work of compassion, and it's a work of, again, advocating so that the parent knows that I'm important, that my voice counts.
Absolutely.
Okay.
Absolutely. Thank you so much.
That was pretty detailed.
Yeah, it was very, very helpful for us to know. And I think one of the
I'm so excited. Something about the last.
Mommy's first.
Yeah.
There's something about the last person who spoke that just got.
All right. Well, I guess we're gonna be doing this the whole show. But thank you so much for what you just said, and thank you so much for what everyone has said. Going through this process, it has been a wonderful process, but also very stressful.
Yes.
Very overwhelming. Very difficult in some ways, with all of the different things happening to your body that you may not have anticipated. And so it is so important and critically helpful to have the support of a doula. I also did not mention this at the start of the show, but in addition to Miss Holston, who is also serving as my mother and grandmother in waiting and a doula, Jasmine is also my doula as well. And so I'm so grateful to have the both of them. But this process has been overwhelming. And so to have the support of someone who's seen that process and can help me to advocate, even though, in my normal life, I'm a lawyer, right? I don't have problems advocating, but everyone has problems when they're, in a hospital setting. And so I want to kind of get into now.
Can I ask one question real quick? What does the word doula mean?
Interesting question.
I can take that one. So the original origin of the word is a Greek word and does mean slave or like servant. But it's been like reclaimed to talk about supporting women in their time of need, especially in this period of giving birth and that journey through it. I love the human epidural. I'm definitely borrowing that. But I always consider myself to be like a liaison and support of a person through this experience. Like Deb talked about, we have that wealth of knowledge, that information to provide for people. And the current climate when it comes to birth in this country, a lot of people are walking in it really like blinded. They don't know the lack of preconception education, lack of sexual education. A lot of people don't know their bodies. They're not tapped into this. So to have somebody who's seen this, who understands it, and can be able to kind of guide you along this process, I can't take over for you, but I can definitely help you get through this and work on some tools and techniques to get to the
I
end.
prefer the word servant than slave.
Yeah, definitely. Yeah. That's why some people will say birth worker too, just the association with the word slave. Yeah.
Okay. Thank you so much.
Thank you for explaining.
Yeah,
that.
definitely.
So, and we've talked about the need for doulas and the need for return to midwifery care and the need for competent care across all sectors, right? We've talked about that. But I'm interested in the why, right? I'm interested in where are the gaps in care. So what is the state of Black maternal health in the city of Philadelphia right now? Because I think all of us have heard a lot of statistics, and it can feel confusing and overwhelming, and it's like, what, just because I'm Black, I'm more likely to experience such and such and such and such, and it's overwhelming, and it's heartbreaking, being a person that's going through that. So, and this question is for anyone who wants to take it. What is the state of Black maternal health care in this city and in the state?
Well, let's give it. Yeah.
So I'll chime in here because even, in the policy work that we do, it is very data driven and very data informed. And so we do here in Philadelphia, we have a Philadelphia Maternal Mortality Review Committee that reviews all maternal deaths across the city of Philadelphia. We have that same committee at the state level, and both of those committees are responsible for providing us with data on the issue. And I think, pre-show, we talked a little bit about data, and yes, there's lots of delays in data, and data sharing is an issue, especially when we're talking about health data, but as much as possible, we try to hone in on the data so that we can understand the issue. And mostly I'm going to be speaking from the state level, but there are statistics at the city level. When we talk about Black women in Pennsylvania, they are over 2 times more likely to die due to maternal mortality than their white counterparts. And that number has risen over the last couple of years. Unfortunately, we also saw nationally that the number has went up. Obviously, that is trending in the wrong direction, which is one of the reasons why, we stepped into this work in the policy space. In Pennsylvania in 2021, which is the latest data that we have, 129 people in childbirth, or people who succumb to maternal mortality. And when we're talking about maternal mortality, that can be during pregnancy or after pregnancy up to a year postpartum. And so, so we use that data policy-wise to try to drive the work that we're doing. Obviously, those numbers, especially as Black women and in the Black community, are daunting, right? Unacceptable.
Yes.
I have not, been pregnant or given birth or anything like that. But as a childbearing age woman, it's scary. It's scary. But there is a lot of work being done, a lot of support, and a lot of providers out here to do that. But right now, it is more risky. Unfortunately, one of the things that we see that we do like to call out is implicit bias.
Yes.
A lot of the disparities that we see are not because of the health of the people. Someone who has a higher education or has a great medical history or has a great health status is a Black person is still at that rate more than 2 times more likely to die compared to a white person that does not, is not of the best health, that does not have a particular education or income level. And so a lot of the data points to implicit bias and racism, which is something that, needs to be addressed across the board alongside access to care, quality of care, et cetera, which are things that we're working on policy-wise, but we know that people are on the ground working on as well.
Yeah. And does anyone have examples of, so we heard the statistics, right? But does anyone have examples of how this plays out in practice, like where you've seen these biases and how they've impacted not just maternal mortality, which is the worst of the worst, but also poor outcomes in terms of maternal care? So anyone feel free to jump in.
Yeah, it is, as I was sitting here and we're talking about the mortality rate, like in my brain, I do lump them both together, mortality and morbidity. And yeah, it's, in the country is terrible. In the state specifically, because we all live here, is also not that great. Just like what you said, it's like between 2 and 4% of Black women are succumbing to some type of negative outcome because of their birth choice or where they're deciding to give birth at. And a big part of it, and not even to go onto that whole level of like insurance policies and like what insurance companies are like forcing these providers to do, right? And a lot of the times,
You can go there. You can go there.
yeah, we need to get more people on that team. And I understand the insurance, it's ran specifically so that we could save money, or so that they could save money, but
Or make money.
But unfortunately, it's affecting our population in the negatives, which is unfortunate. And it's not excusable that a provider walks into a room, somebody laboring, and is putting all of their thoughts on this person, right? But if you think about it, this person came from whatever background they came from, with the household that they came from, the biases that's been going on in that home. But also, too, they've never had the opportunity to really sit down with their patients, even though I hate that word, but they don't have the opportunity. They're in and out of the appointments, right? Labor room, they're dealing with people on the floor, right? No time to sit there and say like, oh yes, let's talk about this informed consent for you, right? And that's a lot of the times why people are hiring doulas, to slow down the vibe inside of the rooms, because they just don't get the opportunity to do that, which I'm pretty sure that that's why it's also affecting us in that way as well too, because they don't know us. They don't know what we like, what we don't like, how to treat us. They don't get the opportunity to know that until you meet. And there's not enough black OBs. There's just people don't even want to go into the obstetrics field in the hospital, which is in itself, but there's not enough people that look like us that will understand what we're going through when we walk into these rooms, when we're trying to give birth in their hospitals, and you're the minority in your birth room.
So just so some clarity on my part, so you're saying it's about implicit bias. It's not about economic differences. It's not about different kinds of about poverty or anything like that. Even when all that is taken into account and equal, the number still comes out 2 times more.
Oh, yeah.
Yeah, so those things play a role overall. The social determinants of health, you know, your income level, your education level, access to things like transportation. But when accounted for and put at the same level, black women are still more than 2 times more likely to die.
Oh, wow.
And one of the references that we often make is to Serena Williams and Beyonce, who have access to, you know, top-notch care that some of us will probably never be able to afford. And still, Serena Williams in her expose talked about not being listened to. And, you know, we hear stories about, you know, black women being assumed that they can tolerate more pain. And those assumptions enter the room with, you know, the care that's being provided, and then you see someone not getting the type of care that they need, including, you know, people that have access to care. Beyonce and Serena Williams could, you know, pay for any doctor to come to provide service to them, but still. Right? They are considered 2 times more likely than someone, you know, that is not of their culture, not of their background, who does not have access to the money that they have, nor the education level that they have.
Yeah, and I mean, I think there's a lot of examples of this, you know, generally in healthcare, right? Where, you know, there's this Instagram video floating around where it says how medical providers will write their notes. And so,
For
you know,
white patient versus a patient of color,
Yes, where they'll say where, you know, for a white patient, they may say they advocated for themselves. For a black person, they may say they were agitated or they were angry, right? So even down to the medical notes. But it's not just maternal mortality, but which is so important to talk about. It's also how children are treated and newborns are treated, right? There's a lot more suspicion placed on black women, which can cause more stress, which can cause poor health outcomes, right? If they believe you're suspected of drug abuse, there's sometimes I believe there are some you know, things that you can ingest that might show up potentially as being as you being a drug user or engaging in substance abuse.
Or even unnecessary testing too.
Unnecessary testing.
because they assume that because you are this age or you're in this population that you, yeah.
And so there's a lot of suspicion, which can again lead to stress and it can lead to poor health outcomes itself. And that's not even to mention all that goes into prenatal care itself, right? We're talking about the labor and delivery process here for the most part, but we're not even talking about when people are suspected, and not so much in Pennsylvania, but suspected of having an abortion or have had coming into the hospital for a miscarriage and then being policed as if they are having an abortion, which was their right in this country to engage in. And so that can also affect overall prenatal outcomes, because if you believe you go into a hospital and you're going to be suspected of something, then that may lead you or discourage you from not going to the hospital.
So can we get back to this black superwoman thing that seems to be prevalent in the medical field, that somehow black women can tolerate pain more, and therefore we don't give the same care. That I mean, I know there's many practical stories around that, but you know, just the manifestation of that, just thinking about that. A black woman in pain, but I know you can handle it more, so I'm not going to care, I'm not going to do the same procedures, I'm not going to give you the same medicine because you can handle it.
Yeah, or not address the problem with urgency as well. I've seen plenty of clients in the hospital. I support a lot of hospital births, but I've seen plenty where a client will ask for epidural. You know, they'll tell you, oh, you can ask for it whenever, but then by the time, you know, you're requesting it, it takes a while, or they get it and then it's not administered properly. And then we're waiting hours to get another one administered. That's not okay. People's pain levels are very high. They're talking about this for a reason, yeah.
And I will add to that point that you were making, that literally, and it was early on, so this was several years ago, it was shared to us, text in a textbook that was being taught to medical students that was
So it's institutionalized.
literally saying that black women could have the tendency to tolerate more pain. And so it was being taught. It's my understanding that those things have been removed at this point, but it was institutionalized, right?
How long ago was that?
It's been a while. This was early on in my work, so a good over 5 years ago. But yeah, that's not a long time. We're talking about giving birth, and we're talking about giving birth.
Teaching that even
Yeah,
5
and
years ago.
it's still
I
ingrained,
thought you
right?
were going to say 20 years ago or
Right.
something.
Yeah. No. Yeah.
That's
So it's still
outrageous.
ingrained, and
you
that means
still
there's
have providers who are taught under
trained
that,
that
yeah.
way, which is why sometimes, from the policy perspective, we're looking at multiple angles. But a part of that is like how people are being educated in this space. One of the bills that Representative Cephas introduced a few times over the last few years was for implicit bias training required for medical professionals, any healthcare providers that touch pregnant people. And it's not when we're talking about policy and legislation, it's not the piece of legislation that's going to move the fastest and make it to the governor's desk overnight. I mean, we've been working on it for 7 years, but it is an angle of attempting to address the issue.
Yeah. Well,
Thank you.
Yes, thank you for that. I want to kind of ask, because I want to get back to we hear these statistics, we hear these things, and it's devastating, right? And you sort of feel like you're at a standstill, or you just don't know what to do, right? And for some women, they are going to still choose to give birth in a hospital. So, I guess what I'm asking is, how can folks balance the mistrust of the system, which permeates not just obstetric care, but permeates various levels of the medical care system in this country, with the need for various levels of care, because we don't want people to not seek the care that they need and not have that informed consent or informed opinions about what should happen. So I'm curious for all of you who are birth workers, how you combat the feelings of mistrust that your patients or clients may have, with also helping them to, get the care that they need.
Well, I would say educate. It starts with education. That's the first thing. And I always tell people in 2025, we have no excuse. We have access to the internet. We have access to social media pages with other midwives and other birth workers that are spreading the gospel, like literally laying it all out. I'm on social media almost every day, and people are like literally, day by day, play out of like what you need to be doing, what you need to be looking for, things that your provider is going to bring up to you that people have no idea about. And I always tell people I'm not in the business of everyone needs to give birth at home, because that's not fair, that's not true, that's not healthy. People are not healthy enough to give birth at home, or whatever the circumstances is, whether it's fair, their health, what they know to be true in the maternal care in this country. So everyone doesn't necessarily deserve to be at home or need to be at home. And in my specific practice, 14% of my clients are going into the hospital for whatever reason, whether that's prenatal, labor and birth, transfers, or postpartum, something's coming up and we need to go into this hospital, right? In the hospital, there's a place for everything, right? There's a reason why we have new advances in technology and all of these medications that they have and all these procedures that they have in the hospital, because some people do need it. Now, usually those conversations starts off with, I don't want to go there. I don't want to go to the place, and this is why, and I'm scared, and all the things like that. And usually I kind of want to always just reel it back into like, we're going into the space for a reason, right? Like we need this one thing, we need this whatever intervention it is, and let me debunk what you're thinking. Like, let me tell you how it's going to play by play of when you get in there, they're going to draw your blood, they're going to come to you, you're going to stay in triage, you're going to go get Will to the back of the hospital, somebody's going to come in, you're not going to know them, and just literally laying it all out there, because no one talks about that part. People think,
Thank you.
first of all, people think that they have one contraction, they're supposed to go to the hospital. That's not how you're supposed to do it. Back in the day, I'm sure you could attest that they used to, the 411 call, like your contractions had to be a certain amount of times apart, and then that's when you want to come into the hospital. Nowadays, we're not doing that. First sign of a labor, first sign of a contraction, we're going into the hospital, right? And that is just a recipe that they're going to experiment on you. They're going to throw these things at you because they want you to continue the journey. They want your labor to kind of progress, so whatever that means, and it needs to look in a specific type of way, and it's really just the education piece, right? Like someone should have told them, like, you're fine, you're okay, stay at home until X, Y, and Z happens, and then come in here and utilize this appropriately, right? We think that just because we go in there, they could take the pain away, give us the drugs, which is cool, and they could do it. That's why they have those things there, but it's not necessarily great to be getting Pitocin at 1 centimeter if everything is fine. Like someone should tell you, no one gets sent home anymore. Like very few people are getting sent home from the hospital because they're there too early. They're gonna keep you, they're gonna do the things.
Or induce you.
I'm like, that's crazy. Yeah, because we were there a couple times and got sent home. Well, we walked the hospital floor a couple times, and that didn't work.
Yeah, they're not as welcoming like that anymore. They tell you to stay in your room. Stay connected to the machine.
Recently, I did have the experience, and I said, you were told you're going to be induced, but I noticed that she had not had any other interventions. And I said, let's walk. And so we checked with the nursing care, and we walked the hall. I gave her an incentive. Let's walk to the vending machine, or let's walk to see what kind of, things they have in the refrigerator or something like that. But I want to get back to the trust and building the trust, because what I do is in my initial meeting with a potential client is I would find out what their experiences have been. Try to get how they are feeling, how they feel towards the hospital environment. How do they feel? Do they feel comfortable talking to, say, a doctor or a nurse? Do they feel comfortable being in that setting? Do they feel comfortable even going into the hospital in the initial intake? So I allow them to share their stories. And then if they share a story where it feels like they're intimidated, or they may have had some kind of traumatic experience where they felt judged, or they felt a certain way, and I always tell them, your feelings are your feelings, and trust your feelings, because no one can tell you how you
Yes.
feel
Yes.
or how someone made you feel, and that's part of my education as a teacher, as an educator, that children remember.
Yes, they do.
People remember, and trauma is something that stays with you, and so that trauma comes back and it visits them, and it goes wherever they go, and we just don't know how long or when it'll turn up. So I try to find those things out, and then I try to listen and affirm and say, yes, that's real. Yes, that's real. Trust what you felt. Trust how you feel. If you feel that there's a person who mishandles you, a person who maybe inserts maybe something into your vein and they hurt you, you have the right to say, can I have someone else to do that?
Yes, yes.
You have the right to say this, and you have the right to also say, wait, before you examine me, or I don't want you to examine me while something is happening to my body. I want you to wait, and so give me time for that. So I teach them more about their humanity, their personhood, even from how clean a room is kept. Because people sometimes in the profession come in, they leave things on the counter, they drop things on the floor, and I may say to them, and I have a smile that can, I think, disarm some medical professionals. And I'll say something like, are the floors supposed to be like this? And they'll go, oh no, how often do people come to clean the room? Because even how the room is kept says something to that person, that I'm cared for, or I'm not cared for, or my voice matters, or I'm just here as part of what is on the floor, trash. So I make them sensitive to that, and I teach them how to speak up, speak out, and not say it in a way that may confront someone, but to say, can I ask you a question? That's a disarming thing, right?
Yeah. And I think one thing that is important, we're talking about some of the gaps in care, and we're talking about some of the interventions, but what positive resources do exist? What are some positive developments that have happened to give people additional support for their birthing process, whether that's at home with a midwife, whether that's in a hospital setting with a midwife or an obstetrician gynecologist, whether that's wherever that is, being able to access doula support via insurance. What resources do exist to combat some of the crisis and some of the things that we're talking about that are going to be helpful for people in supporting them through this process?
Doulas.
So I'll speak to some of the things that we've been able to do at the state level. Now in Pennsylvania, Medicaid. Goodness. Medicaid does cover doula care, and that's a policy that we've been fighting for several years. But it was just passed last year, and so Medicaid is required to reimburse doulas. We did have to create a pathway for doulas to be certified, and so doulas can be certified in the state of Pennsylvania so they can get that Medicaid reimbursement. And so what that does is open up the door to access to care, because we knew that while the data showed us that doulas made quite the difference, a lot of people could not access it because they can't afford it. We're still working on private insurance and that requirement. There are bills out there to require it, but we have not been able to move them quite as much. And so Medicaid coverage for doula services. We've also been able to funnel a nice amount of state funding out into across the state of Pennsylvania. Since the caucus has been founded, over $30 million has been invested in Black maternal health care, and a nice amount of those dollars have been dedicated to coming directly down on the ground. And that was important to us because our stakeholders let us know that we need money down here in the community to do the work that we're doing, the work that we have seen is working. And so a few programs that we've seen have been able to be supported. Here in Philadelphia, we have the Philly Joy Bank, which is a guaranteed income pilot program here in the city. And I forget the number of families that have been able to enroll, but there's a $1,000 stipend that they get, no strings attached. They can use it for all types of things. And so that's something we've been able to support. And, you know, we see families who have been benefiting from that and who've been able to benefit from that. And we're looking forward to the pilot study telling us that it's something that needs to be done long term and be spread a little wider, so that we will continue that work. We've also been able to support a program called Heart Safe Motherhood at Penn Medicine, where the patients are sent home with blood pressure cuffs because we know
I'm a part of that program.
in those days, you said what?
I'm a part of that program.
Okay,
Yeah.
yes. We know that, you know, data has shown us, you know, that the blood pressure and the heart issues that can be associated with maternal morbidity and maternal mortality. And so just being able to provide that resource has been able to allow patients to be connected to their provider even if they can't make it back to the provider. We do have 2 bills that we're trying to push that will require insurance coverage for those same for those blood pressure cuffs and Medicaid coverage for the blood pressure cuffs. But those are just a couple of things at the state level that we've been able to do, and we're looking forward to just keeping that type of stuff going.
I want to know more about the guaranteed income piece. Giving $1,000 to women that are pregnant, or just families in general?
Women. So this is a pilot program for pregnant families, and I forget the requirements. I don't know if either one of.
I think it was like you had to live in a certain neighborhood.
Yeah.
Yes, there was certain
age.
zip codes, and then you had to be at a certain stage of your pregnancy, and the $1,000 is given up to I think for about 18 months.
18
So
months.
so even after birth, like there are several months that they're able to access this or get that support beyond there, and the big thing is no strings attached. Not telling you where you can spend your money. You have to spend it on this kind of food, or you have to spend it on this type of whatever it is. There's people, what we see is that people are using it for housing. I think that's one of the biggest things that we've been seeing that people have been using it for, which is, you know, the housing crisis that we have in cities like Philadelphia. And it can make all the difference. But also transportation, or caring for the other children in the family, or, you know, taking care of some of the bills that otherwise they would be stressed about and, you know, would impact their overall health. And so that no strings attached is really the big component that stands out with this particular program. And we're confident that it is having a great impact, but also hopeful that we'll be able to support work like that more widespread.
I'm so glad that.
And congratulations, yes. I'd love to meet people who've been able to.
I'm so glad that the Philly Joy Bank has been implemented, and it's almost should be intuitive, right? The idea that you give people money to live and to take care of their needs as they determine them, and they do better. They have better health outcomes. Giving birth is expensive. It's extensive co-pays. You know, there are many things and items that are not given to you via the healthcare system, but if you want to support your own birth, you get those things. And that's not even to mention all of the baby items that you're preparing for, right? So giving birth is quite expensive, and so I'm so glad that that pilot program exists, and I hope that it's able to be expanded and that people take it seriously, right? But one thing I wanted to talk about, and you also mentioned the Heart Safe Motherhood program, which from my experience has been, I've just been given a blood pressure cuff at my doctor's appointments. Do you need one at home? I even said, hey, I already have one, but I'll take an extra one for my upstairs. And they give me an extra one. And it's, what happens is I receive a text message every week saying, it's time to take your blood pressure. And I send in my blood pressure. And if my blood pressure looks great, they send a text message back saying, looks great, everything's wonderful. If there are issues, the doctors or the nurses will follow up the next day, or even sooner in some cases, and we'll try and figure out what's going on. So it's a great resource, and it helps to, solve issues before they start. One thing, were there other resources or other positive interventions that people are aware of that they wanted to discuss?
I wanted to mention one. So I'm really big on advocacy and helping people advocate for themselves, feeling empowered to do it. And I feel oftentimes when it comes to birth, a lot of people feel more invested in their medical care because of it. And so they listen to these medical authorities, right? Their doctors and nurses that are there kind of giving them information. But I really try to push for people to kind of be in tune with themselves and understanding too, like you can get quality care where you deserve the information that you can receive accessible to you. So one of the things that I push is the Earth app. It's a Yelp-like review app where folks can look up different hospitals or doctor's offices, pediatricians' offices, and they can see reviews given, honest reviews from their peers about what's going on there, so they could be able to be accountable for their health and where they want to go.
I love that.
It's a great opportunity to just look around for that and feel empowered that you're making a decision for yourself, your betterment. We're seeing a lot of people get a lot of mistrust from providers, so you want to feel like you're in good hands, good, competent hands.
Absolutely.
Yeah, the assumption that simply because a doctor is in front of your name is that person is competent.
Oh yeah.
Or
they care about your health.
They care about your health.
Mm-hmm.
In fact, many doctors don't care about your health. They went in the industry because of the resources or the dollars or the prestige, and they actually don't care about people.
But we also know that, as you alluded to earlier, that if you have a Black birth worker, you're much more likely to have positive outcomes. And there's been some discussion about that, right? There's been some pushback on that idea that that's somehow racist if you are saying that Black birth, or if you want to choose a Black birth worker, somehow that is racist. But we know that statistically it is the case. If you have a Black OB, if you have a Black doula, if you have a Black midwife, you're much more likely to have better outcomes. And so the more individuals that are going into these fields who look like us, who come from similar backgrounds, that's important, and I've been happy to have that.
Black women like they're super and they can handle any amount of pain. Maybe that wouldn't be an issue.
Sure.
But if you have Black folk who understand what Black women go through, they're actually working with you. I think that is something that should happen.
And can also recognize things. I've had clients, I won't name the hospital, but they had fibroids and worked with a hospital that had never seen fibroids in pregnancy, and they're treated like lab rats, and they're kind of like, this is weird. But to have a provider who can understand this, who can resonate with you, who can understand and talk to you about these things, that's really important.
Yes.
That representation does matter.
Absolutely. I did just want to bring in one piece, which is, and I wanted to talk with you about some of your birthing experiences, either for your personal birthing experiences, try not to get too embarrassing, or through some of the experiences you've had working as a doula, about the impact of your birth partner or your birth support people in this process. And one of them is here today, right? And so when we talk about...
Well, so she get the question, but I don't get the question.
That's correct, because it's talking about her experience with her birth partners.
I think it's important
Well,
to have the male give a perspective as well. So I'm willing to listen.
I think let's start with Ms. Holston.
Yes, we want to encourage young men to be a part.
I was trying to go there,
Oh.
but you didn't actually give me the opportunity.
All right.
My birth experiences, I have had 3 birth experiences, all different, in fact. One was a Black male doctor, or DO, didn't matter. That was the first experience. And that, my mother was there, so she wasn't in the room, but she was there. My husband was in the room, and it was an interesting experience because it was the first time, of course, but we went through the birth without any problems at all. In fact, with all 3 births, they were natural without any kind of pain or any kind of intervention other than my husband being there and the professionals taking care of me. The second birth was your birth. I did have a midwife, however, we didn't get a chance to use her or to use them because as things would have it, my water broke at home and someone drove us to the hospital. So I was there probably a total of 45 minutes, if that, and you were born.
Okay.
And then the last birth was my son, and that was in a women's birthing center, birthing suite, the midwifery, and I think that left the most positive feeling or experience that I've had in all of my pregnancies because it was caring. It was family-centered. My family was there. The godmother was there. Dad was there. And another person, I think, was there. They were very patient with me. I got a chance to be in the hot tub. I got a chance to walk the halls. We had a kitchen area and an area where the family could gather as well, and I could gather there. And so they were very, very patient with me, and they informed me that the baby is going to probably come in the morning, and the baby did come in the morning. But that was the most, I think, personal and intimate of all of the births. Patient, caring, I had all the support around me. So I, of course, will always advocate and say thank you to midwives. And so I encourage that kind of setting with those who I encounter. So those were my experiences.
And you want to talk about the importance of birth partners and supporting.
Listen, partner support is great.
Supporting.
We got the Pennsylvania Dads Matter Act
Pennsylvania
to
Dads
honor
Matter.
the work
Yes.
that is necessary.
So our first child, it was really just the doctor was male and I'm male. Mom really wasn't in the room much.
No, she wasn't.
No, and that was something. About 6 hours in labor, 6.5 hours in labor. And without getting too much, it was bloody.
Well, we had gone through classes
Yeah.
together as well.
I mean,
so.
it just, some circumstances happened that caused it to be a little bit bloody. But I mean, I was just so happy for Jamila coming out and all that happened, and watching the head come out and all that, and being able to catch her, and that was just a joy. The joy, the blood and all the other stuff didn't even matter. And then this one, we wanted to go to the birthing suite, but she decided we weren't going to the birthing suite.
You don't need to.
And she came so fast. I'm sorry. Stop. My son was 36 hours.
Oh, okay.
Yes, in that birthing suite. And while we prayed later, I got to spend time with him in the birthing suite and to just hold him and pray over him, which I didn't have with the time in the same sense because of the hospital rooms. Birthing suite allowed for more, my own communal time with my child. And so that was beautiful. We did the roots thing,
Yeah,
but all of that is a recognition that a lot of what she went through was her experience. I was seeing stuff she didn't see, and so my experience took a different spin because I'm seeing what she's going through, and trying to respond. There was, in our first child, and I'm saying this quickly, every time the machine would go up to say that the pain was happening, I was saying, okay, it's going up. It's coming down now. You're doing good. It's coming down. You'll be all right.
It's giving us some anxiety.
Yes,
I'm sure.
I was certainly doing that. 'Cause nobody told me I should not do that. But when after it was over, she let me know. Don't do that no more. So there's some learning experience. I think if young or any man who is getting ready to have a child, it's good to hear from other men who have gone through the experience of what that's all is, so that I would have known not to say that, and probably some other things I would have known not to do as well. We are leaving right now this program. We've had such a great conversation,
Yeah.
but our time is up.
Wow.
Thank you so much again being with us here at Just Nation, and stand with all of us as we work together to build a just, a fair, and a racially just nation. Take care, everybody.
All right, bye-bye.